streaming vittara.
Hello everyone. Hello. Hello. Yeah. Yes. Yeah, there is some internet issue, yeah. Okay. So please share this on your respective groups, this link, so that we can continue with this. Okay. The internet also wants to go for a long holiday, I think. It's creating a lot of issue today. Yeah. So I was asking, yeah, it is live. You can join this. Arpita, Dr. Arpita, can you post this YouTube link again on all your groups? Yeah. Shraddha, you can also do it. Okay, please help your friends because they are messaging on the groups. So I am currently linked to YouTube. So yeah. So my second question is, a peripheral facial nerve palsy will have everything except. Okay, I'll wait for your answers. A peripheral facial nerve palsy will have everything except. Why see? A flat nasolabial fold means there is loss of nasolabial fold. That is definitely seen in a facial nerve palsy. Read the options correctly. Loss of wrinkles on the forehead? Yes. Non-closure of the eyes? Yes. Flat nasolabial fold? Yes. Drooping of mouth on the opposite side is wrong. It is on the same side. Right? It is on the same side. So that is why I have kept this question, right? So if we have a look at the different types of palsies, what is this? This is a central lesion here. Can you see a central lesion? Okay, this is a upper motor neuron type of lesion. Okay, so this is also called as central facial palsy. What happens in central facial palsy? Okay, so there is a crossing over that occurs, and which side is affected? Can anybody tell me which side is affected? The same side or the opposite side? In a central. Which side is affected? Opposite side. Yeah. Whereas if you consider this, which is a lower motor neuron lesion, this is a type of peripheral lesion. Okay, this is a type of peripheral lesion. Okay, so the same side is affected. Right? Same side is affected. Okay, that was our question. Right? So in a peripheral facial palsy, you see same side being affected. You don't see opposite side. I hope everybody got it. right? I hope everybody got the answer, right? So be very clear about what a central and what a peripheral palsy means, and what you can see on a central palsy and what you can see on a peripheral palsy, right? Clear, everyone? Yeah, let's go to the next one. Which test is more appropriate for extrinsic pathway deficiency? Which test is more appropriate for extrinsic pathway deficiency? Prothrombin time, activated partial thromboplastin time, INR, both A and C. D. You're correct. It's both A and C. So if we have a look at the pathway, I know everybody knows the coagulation pathway. So the intrinsic pathway, you have starting with the Hageman factor, and the extrinsic pathway, the only factor that is involved is your factor 7. Right? So if you look at the test, this is a very, very important table. The test that measures your extrinsic pathway is your prothrombin time. Okay, and a ratio of prothrombin time to a control patient, okay, to a standard patient is called as an INR. Okay, so your INR less than 1 is always considered to be normal. Okay, and your prothrombin time normal is about 11 to 12 seconds. Okay, so if you have to measure whether your extrinsic pathway is functioning properly or not, you do a PT-INR. Okay, and if the same thing has to be done for the intrinsic pathway, you do a activated partial thromboplastin time. Right? So this is clear. Okay, so everybody knows the list of coagulation factors, right? From factor 1 to 13, it can be asked as a match the following. It can be asked as a normal MCQ question. So please, everybody remember the names, okay? One thing I want you all to remember is here partial thromboplastin component and partial thromboplastin antecedent. So component is your factor 9 and antecedent is your factor 11. Okay, please remember this, right? Next one, a 9-year-old, okay, a 9-year-old child shows profuse bleeding after tonsillectomy. Okay, blood shows that the platelet count is normal, right? Prothrombin time is normal, but only APTT is increased. Okay, APTT is increased means it is which pathway that we are talking about? Talking about the intrinsic pathway, right? Yeah. What is the condition can be? The condition can be A. Very good. It can be von Willebrand's disease. Now, if I ask you the question, why not hemophilia? Why not hemophilia A and B? Because they are also intrinsic deficiency disorders, right? Why not A and B? Why not hemophilia A and B? Why only von Willebrand? Why only von Willebrand? There is a reason for this. I'll give you the reason. Here, the gender is not mentioned. Okay. Hemophilia is more common in males. Right? Females are usually carriers. Okay. When the gender is not mentioned, it's always best to go for von Willebrand disease. Okay. Correct. Okay. It's always best to go for von Willebrand disease. Okay. I hope this is clear for you. Right? So, if we talk about hemophilia, right? So, in hemophilia, I'm sorry. Right. So, it's a genetic disorder, right, where you have excessive bleeding. I hope everybody knows this, right? So, either because of factor deficiency of factor 8, 9, okay, there are other factors also, usually intrinsic pathway factors which are deficient cause hemophilia. So, you have epistaxis, you have bruises, you have purpura, you don't have purpura, okay? You have epistaxis, you have bruises, you have bleeding from the gingiva, right? For swollen joints, you have symptoms of hemophilia. So, as everybody knows, right, there is what happens, the pattern of how hemophilia is transferred, right? So, if you see here, this is a a male that does not have the bleeding disorder. Okay, and she is the mother who is a carrier. Okay, so how many offsprings are more prone to having the disorder? Can anybody tell me? How many offsprings have the disorder? I am just asking you, how many offsprings have the disorder? Tell me in percentage. You can see it on the screen. Okay, 50%, that is one male and one female are having the disease. Okay, among those 50% also, 25% are carriers and 25% are completely affected. Okay, so this lineage of transfer of genes of hemophilia is very, very important. Okay, so they can give you a normal mother, or they can give you a carrier mother, okay, or an affected mother, okay, with a normal father or a carrier father. So how much is the percentage of offsprings that tend to have the disease or that tend to be the carriers? Okay, so these sort of genetic based questions can be asked. Okay, so these you have to remember. Okay, these you have to remember. Okay, so you know, based on the percentages, it's either normal, mild, moderate or severe. So mild is somewhere between 40 to 5% of clotting factor, 1 to 5% is moderate, and less than 1 is severe. Less than 1 is severe. So the same thing again we are discussing here. So in hemophilia A and B, activated partial thromboplastin time is prolonged. Okay, and in von Willebrand disease, this can be normal or prolonged. Right. One more thing in hemophilia is your bleeding time, your platelet count and your prothrombin time are normal. Whereas when you come to von Willebrand, normal, but bleeding time can be normal or prolonged, and platelet count also can be normal or reduced. So we don't have a per se saying that it's always normal in von Willebrand. So these factors are variable. Only your prothrombin time can be absolutely normal. The other factors are variable. Okay, so these are your types, right? Everybody knows A and B. So C is deficiency of factor 11. Okay, and hemophilia 5 is also called as parahemophilia. Okay, parahemophilia. So definitely it is an X-linked recessive. Okay, the pattern of inheritance. Okay, if you come to hemophilia C, it's autosomal recessive, and parahemophilia is also autosomal recessive. Okay, so von Willebrand, you know, it is a qualitative and a quantitative factor deficiency of factor 8, okay, which leads to a bleeding disorder, okay, which is also called as a von Willebrand disorder. So you have three types of von Willebrand, type 1, 2 and 3. Okay, they might ask you very commonly which is the most common or most affected type of von Willebrand disease is your type 1, where around 80% of cases are there. Okay, 80%. Again, the inheritance is autosomal dominant here. Okay, and it is a type of quantitative defect. That means enough amount of von Willebrand factor is not produced. Okay. So the same thing happens here. So easy bleeding, easy bruising, skin bleeding. Okay, all that can be seen. And here, what is normal? What is normal in von Willebrand disease? Can anybody tell me? Just now we saw what is normal. What is the only entity that is normal in von Willebrand? The bleeding time. Okay, the bleeding time, right? So the same thing here again. Let's go to the next one. Which of the following blood products can be transfused in von Willebrand's disease? Are you able to see my screen? Yeah. So which of the following blood products can be transfused in von Willebrand's disease? FFP, cryoprecipitate, both A and B, none. C. Very good. Both A and B. Why both A and B? So here we come. So in von Willebrand disease, we have to give factor 8, right? So which all have factor 8 or which all have von Willebrand's factor? You have fresh frozen plasma, okay, and you have cryoprecipitate, which have, okay, von Willebrand's factor. So the compositions of all these plasma products, that is your fresh frozen plasma, your cryoprecipitate, what it has, what it does not have, all this is very important. So please go through the various composition of all the plasma products that are available, okay, for blood transfusion in hemophilic and von Willebrand disease patients. Next one, rule of 10 is applicable for. Rule of 10 is applicable for. C. It's applicable for both pheochromocytoma and cleft lip, right? So how in cleft lip, so it's a Milliard's criteria that is used for cleft lip repair. So when you do it when the infant is 10 pounds in weight, okay, and 10 weeks old, and he has or she has 10 grams of hemoglobin, okay. This is your Milliard's criteria, rule of 10, okay, 10 pounds in weight, 10 weeks old, and when the patient is having 10 grams of hemoglobin. The same thing can be seen in a pheochromocytoma. Okay, what is this? In a pheochromocytoma, the rule of 10 says that pheochromocytoma is a benign tumor, okay, of the adrenal glands, right? So if it becomes malignant, only 10% chances are there that it becomes malignant, okay. Usually it is unilateral, okay. 10% chances are there that it can be bilateral, okay. It can be present in other organs like organ of Zucker-Candle, okay. So that's why 10% can be extra-adrenal, okay. 10% can be multiple, 10% can be familial, and 10% are seen in children, okay. So this is the rule of 10 of pheochromocytoma, okay. Pheochromocytoma, rule of 10, both in cleft lip as well as pheochromocytoma, okay. Let's go to the next one. Late congenital syphilis includes. Sebacean, Clutton joints, Regadus, all of the above. I'm waiting for your answer. I'm talking about late congenital syphilis. Very good. All of the above. All of the above is the answer. So you know the stages of secondary mucocutaneous patches and also condyloma latas, okay. Then you have tertiary, which affects the heart and your brain, okay, in the form of gummas, right. So if you come to congenital syphilis, you have two types, that is your early and late. Early is from the birth till the second year of life, and late is after the first 2 years of life you have congenital syphilis, usually from second year to fourth or fifth year, okay. So what do you have? Okay, you can see you have Sebaceans, Clutton joints, okay, and you have Regadus. Regadus is nothing but the fissuring that you see, perioral fissuring that you see around the mouth, okay. Whereas in congenital, early congenital syphilis, you see Hutchinson's triad. Sorry, you see late congenital syphilis, you see Hutchinson's triad, which includes your mulberry molars, your peg-shaped incisors or screwdriver-shaped incisors, okay, interstitial keratitis, sensorineural deafness, all that can be seen, okay. So you have to be very clear about the things that are concerned with syphilis, okay, your primary, secondary and tertiary syphilis, the characteristic features of each and everything, and what is happening in early congenital and what is happening in late congenital. So all symptoms that we saw, all signs that we saw right now are your Sebaceans, Clutton joints, Regadus, all those are of late congenital syphilis. Okay, what is this Higuminaki sign? It is the thickening of the sternoclavicular portion, okay, of the clavicles, right, which can be seen in congenital syphilis. Again, Buschke-Ollendorff sign, okay, this is in secondary syphilis. Please remember this. This is in secondary syphilis where there is a deep terminal tenderness, okay, on pressing the mucocutaneous rash that is present on the body. Okay, this is called as Buschke-Ollendorff sign. Okay, so and there is one more sign apart from these two signs that is involved with syphilis. Can anybody tell me? That is also seen in congenital syphilis. Okay, apart from Iguminaki's sign, apart from Buschke-Ollendorff sign, there is another sign. Can anybody tell me? It is the Du Bois sign. Okay, it's the Du Bois sign where there is a little finger, shortening of the little finger that you see in congenital syphilis. Right? Yes, Dr. Supraja, you're correct. Du Bois sign. Okay. So, next, going to the next question. The sequence of tongue changes seen in scarlet fever is? Which tongue is followed by which tongue in scarlet fever? I am waiting for your answers. Very good, Dr. Anjima. Yes, it changes from a strawberry to a raspberry tongue. Yeah. So first you see a white coated tongue. Okay. Followed by a strawberry tongue. Okay. Followed by a raspberry tongue. Okay. So in strawberry tongue, there is erythema of the tongue followed by partial loss of papillae. Okay. Which gives the typical strawberry kind of appearance. Okay, then when there is complete atrophy of the papillae, it becomes a deep red raspberry tongue. Okay, so strawberry tongue is followed by raspberry tongue. To see me now, students? Can you see me now? Yeah, yes. So this was what we were discussing. So from a white coated tongue, it proceeds to a strawberry tongue. Okay, then the last one will be your raspberry tongue. Okay, so these are your very important points about scarlet fever. So apart from that, the other important points about scarlet fever are, right? So the sandpaper rash, okay, then your posterior lines, okay, which are your linear petechiae in the flexural areas, okay, then your Philotov's mass, that is your circumoral pallor that you see in scarlet fever, okay. So all these are important points about scarlet fever, okay. And intraorally you see the Forchheimer spots, okay, you see the Forchheimer spots, which are nothing but palatal petechiae. Usually that's seen in the hard palate and the soft palate region, okay. So let's go to the, so what are these spots that you're seeing associated with measles here? You see in the buccal mucosa, okay, on the palatal mucosa. What are these spots which are seen in measles? Called as, are they Koplik spots? Yeah, so they're called as Koplik spots, okay, they're called as Koplik spots. Right? So you should know Koplik spots is associated with measles and Forchheimer spots are associated with German measles. Okay? And the other one is scarlet fever. And also you can see it in infectious mononucleosis. Okay? Right. So what is this? The next question is, cold abscess is a type of TB, impetigo, carbuncle, actinomycosis. Yeah, it's a type of TB. Okay, it's a type of skin TB. So if you can see here, okay, there will be lymphadenitis first, okay, and all these discrete matted lymph nodes that you see in TB, they will come together, okay, and they will undergo adhesion, okay, and the central portion of that will form pus, okay. So that is called as a cold abscess. Why is it called as a cold abscess? Because the signs of inflammation are not present, okay. Then from the deep fascia, from the dermis, it will extend through the epidermal dermal junction, through the epidermis and outwards onto the skin. So when it extends, it forms a collar like structure that is called as a collar stud abscess, okay, and externally it will come out of the skin and rupture and pus will come out, okay. All these are stages of your TB that is seen in skin, okay. Your lymphadenitis, then matting of the lymph nodes, cold abscess, followed by collar stud, followed by sinus formation. So what is TB of skin called as? What is TB of skin called as? It's called as lupus vulgaris. Please remember, very important, okay, lupus vulgaris, okay. So on a diascopy test, you see something called as a apple jelly nodules, okay. So when you press a glass slab on the skin of a patient having TB, okay, you see yellow brown spots in the form of apple jelly nodules, okay. So these are very important. These are very important, okay. Next one, a 20-year-old female presented to the OPD with a painless swelling of the left jaw with some exudate. Okay. Now they are saying that sulfur granules are found in this exudate. Okay. What is the most common diagnosis? Can you tell me the most common diagnosis? Actinomycosis, botuliomycosis, both A and B, or is it TB? C. Yes, it is A and B. So, when you see sulfur granules in your question, any case history based question with sulfur granules and saying that he has a jaw swelling, usually near the angle of the jaw, you have to close your eyes and think about actinomycosis. Okay, actinomycosis. But also, there is another infection called botuliomycosis in which you can see sulfur granules. So, since both are in the options, both A and B will be the correct answer, okay. Extraoral swelling near the angle of the jaw, okay, and then you can see as you can see, sun ray appearance of actinomycosis on the histopath and sulfur granules which have the active bacterial bacilli. Okay, it is nothing but active bacterial bacilli. Okay, so sulfur granules, please go for actinomycosis. Okay, 11th one. CSF glucose are normal in which type of meningitis? CSF glucose levels are normal in which type of meningitis? Viral, pyogenic, tubercular, carcinomatous. Good, Priya. Yes. Any more answers? It is viral. Okay. So, please remember, when they say CSF glucose normal, always think of viral. Okay. So, if we see the differences between viral and bacterial meningitis, okay, come to CSF glucose and protein. Okay, glucose levels are normal or slightly reduced in viral. Okay, where they are very much reduced in bacterial. Okay, very much reduced in bacterial meningitis. Okay, protein is elevated but not too very much as compared to bacterial meningitis. Okay, so usually the glucose and protein of a viral meningitis is normal usually. Okay, even if you consider the elevation is very marginal compared to a bacterial meningitis where the elevation is huge. Okay, so this difference between viral and bacterial you should definitely remember. Okay, you should definitely remember. Let's go to the next question. Which of the following are long-term complications of diabetes mellitus? Peripheral neuropathy, non-healing ulcers, retinopathy, all of the above. D, all of the above. Yes, you are correct. Okay, so as you all know, diabetes is of two types, 1 and 2, insulin dependent, insulin non-dependent. Okay, so if we come to the major complications of diabetes mellitus, you have microvascular and macrovascular complications. So among that you have retinopathy, okay, visual disturbances in patients who are affected with long-term diabetes. Then nephropathy. What is diabetic nephropathy also called as? The other name? The other name, diabetic nephropathy. Kimelstein-Wilson's disease, right? Kimelstein-Wilson's disease, right? We'll be seeing about it in the next slide. Okay, then peripheral neuropathy can be seen. Okay, because of which the patients are don't have sensations in the legs, where they don't feel that even after a trauma, they do not feel that they do not feel the pain sensation because of the peripheral neuropathy. So non-healing ulcers because of that. Okay, because of decreased immunity in diabetic patients. So all these are major complications of diabetes. Okay, and intraorally, if you see, definitely you will have the major complication, that is periodontitis. Okay, the periodontal health is affected. Apart from that, you also have xerostomia, so which it can lead to secondary caries formation. There will be taste abnormalities. Okay, and you have read that definitely in one syndrome, that is your Greenspan syndrome, which is a triad of lichen planus, diabetes mellitus and hypertension, you see diabetes mellitus. So also oral lichen planus, you can see in diabetes patients you can see oral lichen planus, and also in patients who are taking antihypertensives and anti-diabetic drugs also you can see oral lichen planus. Okay, so all these are your presentations, or all these are your long-term complications of diabetes mellitus. Okay, so this was what I was talking about, where you have acellular hyaline-like deposition in the mesangia. Can you see this? This is called as Kimelstein-Wilson's disease. Kimelstein-Wilson's disease. Okay. Next, acute change. Okay, mark my words. Acute change in blood glucose is best monitored by which of the following parameter? Acute change is best monitored by which of the following parameter? Is it HbA1c, FBS, RBS, fructosamine? Why FBS? Why HbA1c? Nobody is getting the correct answer. The answer is fructosamine. I am talking about an acute change. HbA1c will give me a chronic change. Okay, past 3 months. Okay, FBS and RBS will give me the current change. Okay, whereas an acute change, less than 3 weeks change, is given by a fructosamine level. Please remember this. Okay, so when we talk about a when we talk about a long-term management of patient having diabetes mellitus, you do a glycosylated hemoglobin levels. So based on that, usually a good level is between 7 to 9. Okay, so anything less than 7 is excellent. Okay, whereas anything more than 9 will be a poor. Okay, so this is how a patient diabetic control is measured based on HbA1c's level. Okay, then you have fructosamine, serum fructosamine, which is a glycated protein again, which will give you an acute change. Please remember this. When they mention anything less than 3 weeks of duration, or when they say in a case history saying that you have given a anti-diabetic drug today and after 3 weeks you want to see whether the patient has improved or not post that anti-diabetic drug, which test will you do? You will do a fructosamine test. You will do a fructosamine test. Next, which leukemia is associated with Philadelphia chromosome? Very easy question. Philadelphia chromosome, which is translocation 922. Both long arms, right? These are very, very important. So where do you see? D. Definitely you see in CML. You see in anything else other than CML? CML should be your choice. Okay, if this question is given, your answer will be D. But can you see in anything else other than CML? You can also see it in ALL. You can also see it in ALL. So this is your Philadelphia chromosome, right? Translocation 922 in both long arms, okay, which is seen in CML, okay, but you can also see Philadelphia chromosome in ALL. Please remember this, okay, please remember this. So summing up the leukemias, okay, so as we saw, CML, okay, it is rare in children, okay, ALL is common in children. It is common in children, okay. So CML, ALL, both have Philadelphia chromosome. CML is rare in children, whereas ALL is common in children. Okay. Most common leukemia of adults will be CLL. Most common leukemia of adults will be CLL. Right? Okay. And if you look at the peripheral smear, the important things you have to remember, rods are seen in which type of leukemia? AML. They are seen in AML type of leukemia. Okay. Then, one more thing. Where do you see smudge cells? Okay. Smudge cells. These are the smudge cells which lack any identifiable cytoplasmic membrane or nuclear structure. Can you see here? Okay, these are called as smudge cells. Okay, which are characteristic of CLL. They are also called as basket cells. Please remember that. Okay, they are also called as basket cells. Okay, so you see air rods in AML. You see CLL, smudge cells or basket cells. Okay, right? Okay, and intraorally definitely you see gingival hyperplasia secondary to the infiltration of the gingiva by the leukemic cells. Okay, by the leukemic cells. Okay, and this is this is a repetition of the discussion that we had, okay, on the group. So if they give you any case history based questions to identify or diagnose the type of leukemia, how do you go about it? Okay, how do you go about it? So if they give you any leukemia with adenopathy, please think about lymphocytic. It can be either acute or chronic. Okay, and if they give you about splenomegaly, please think about anything that is chronic. Okay, either CML, CLL or hairy cell leukemia. Okay, and the leukemia which has neither is your AML. Okay, so this is how you go about diagnosing it. This is how you go about diagnosing it. Okay, so let's go to the next question now. Yeah, which cells of the pancreas are hyperglycemic in nature? Very, very easy. with cells of the pancreas are hyperglycemic in nature. Alpha, beta, delta, pp. Hyperglycemic in nature, I am saying. That means release of hormone from which cell will increase blood glucose? It is an alpha cell. Okay, it's an alpha cell which releases glucagon, right? Which releases glucagon. So that raises your blood glucose levels. Okay, so please understand the question properly. Okay, the cell which is hyperglycemic is alpha cell, okay, which releases the glucagon, whereas beta cell releases insulin, which lowers the blood glucose levels. Okay, then you have your delta cell which releases somatostatin. Okay, so it is an inhibitory hormone for growth hormone that is released from the anterior pituitary. Okay, then you have pancreatic polypeptide cell which releases pancreatic peptide. Okay, then one more thing, please remember, an epsilon cell, okay, which releases an hormone called as ghrelin. Okay, which releases an hormone called as ghrelin. Okay, next question, which is the only lab parameter that is increased in iron deficiency anemia? Which is the only parameter that is increased in iron deficiency anemia? Iron, ferritin, total iron binding capacity, transferrin saturation. A very, very important question and a very, very frequently asked question. Very, very frequently asked question and quite an important question. Very good. Total iron binding capacity. The only parameter, that is the only lab parameter that is increased in iron deficiency. Rest all are decreased. Rest all are decreased. So you know the common symptoms of iron deficiency anemia. You should remember koilonychia, okay, tachycardia. All these are common symptoms. I am not going to go into details of it. So if we look at the laboratory tests here, okay, can you see this? Which, yeah, the total iron binding capacity is the only thing that is increased. Rest everything is decreased. Okay, your hemoglobin, okay, your MCV, MCH, MCHC, RBC, reticulocyte, okay, then your serum ferritin, serum iron, transferrin saturation, everything is decreased. Okay, the only thing that is increased is total iron binding capacity. Okay, and they will ask you very commonly, what is the syndrome associated with iron deficiency anemia? That is your Patterson-Kelly syndrome or a siderosphenic dysphagia. Okay, which is a triad of microcytic hypochromic anemia with glossitis and esophageal webs. Okay, dysphagia is most common symptom of presentation. Okay, going to the next question. A patient presents to the OPD with the chief complaint of dysphagia and burning mouth. Okay, her hemoglobin levels are found to be 9 mg. That means the hemoglobin is less. Okay, and we know that she is complaining of dysphagia and burning mouth. So definitely there is some kind of anemia. We know. Okay, the peripheral smear suggests microcytic hypochromic anemia. The possible diagnosis could be iron deficiency, thalassemia, sickle cell anemia, A or B. Everybody is saying iron deficiency anemia. Why can't it be a thalassemia? Thalassemia also has microcytic hypochromic, right? The answer is D. I'll tell you why it is D, because here we don't know the age of the patient, okay, and we don't know the sex of the patient. These two are missing parameters for us. Okay, the only parameter that is given is the patient is anemic and he is having a microcytic hypochromic level. Okay, that means in that case it can either be iron deficiency or thalassemia. So how will you differentiate? Okay, you will differentiate based on Menster's index. Okay, you will if a MCV and RBC are given in that question. In our question it was not given. If it was given in that question, okay, so please go for MCV by RBC. Okay, if it is more than 13, it will be an iron deficiency anemia. If it is less than 13, it will be a thalassemia. Very, very important. Okay, very, very important. Right? Yeah. Next one. Which of the following is not a radiographic presentation of thalassemia? Chicken wire, pepper pot, rib within a rib, hair on end. Which is not radiographic presentation of thalassemia? Chicken wire, pepper pot, rib within a rib, hair on end. I am waiting for your answers. B. Very good. Pepper pot skull. Where do you see pepper pot skull? You see it in multiple myeloma. You see it in multiple myeloma. Punched out, multiple punched out radiolucencies is called as a pepper pot skull or a raindrop skull that you see in multiple myeloma. Okay. So if you are talking about thalassemia, if you look at the radiographic pictures, you have a hair on end appearance, you have a rib within a rib appearance, and you have a fish mouth vertebrae appearance. Okay. And also you can see there is a blurring or disappearance of the trabeculae. Okay, near the joint. Okay, so this type is called as a chicken wire appearance. Okay, chicken wire appearance, right? Okay, so that was about radiograph. On a peripheral smear, what do you see? You see bullseye cells. Okay, bullseye cells or target cells. Can you see here? Okay, which appear like bullseye lesions. Okay, so these are called as codocytes. Okay, then also you can see safety pin cells on the smear. Okay, and you see inclusion bodies called as Fessar's bodies. Okay, you see inclusion bodies called as Fessar's bodies. Okay, next, going to the next question. Zollinger-Ellison syndrome includes everything except, pancreatic tumor, peptic ulcer, gastric hypersecretions, insulinoma. Very good, Dr. Ranjima. D. Okay, the answer is D. It does not include an insulinoma, it includes a gastrinoma. Okay, insulinoma is diagnosed by Whipple's triad. Okay, Whipple's triad. Okay, so if we look at the triad of Zollinger-Ellison syndrome, okay, you have hypersecretion of gastrin. Okay, then which leads to a pancreas, which is because of excessive amount of pancreatic or duodenal tumors. Okay, so excessive secretion of gastric causes ulceration in the stomach. Okay, so peptic ulcers. Okay, this is a diagnostic triad of Zollinger-Ellison syndrome, which is characteristically seen in a gastrinoma. Okay, next, match the following. It's a very, very important question. Okay, many times it has been asked. Okay, the eye presentation, the eye signs that you see in various amounts of diseases. Okay, so rot spots. Where do you see rot spots? Match it. Where do you see rot spots? Rot spots are seen in very good. It is seen in infective endocarditis. So, rot spots are seen in infective endocarditis. Sorry, 2. They are seen in infective endocarditis. Where do you see bite-out spots? Where do you see bite-out spots? A is 2, correct. Where do you see bite-out spots? You see bite-out spots in vitamin A deficiency, right? B is 4, right? Where do you see Kayser-Fleischer rings? Kayser-Fleischer rings are seen in Wilson's disease. 3. And where do you see Brushfield spots? They are seen in Down syndrome. So, it is a 2, 4, 3, 1. So, if we look at each thing, Okay, rod spots are nothing but retinal hemorrhages seen in infective endocarditis. Can you see this? Okay, these are rod spots seen in infective endocarditis. Okay, next you see bitoid spots, which are hyperkeratotic plaques. Okay, that you see in vitamin A deficiency. Okay, that you see in vitamin A deficiency, which are called as rod spots. Okay, this is also seen in retina. Okay, your which are called as bitoid spots. Okay, which are called as bitoid spots are not seen in retina, they are seen in conjunctiva. Sorry, vitamin A deficiency, these are seen in conjunctiva. Okay, rod spots were seen in retina, these are seen in conjunctiva. Okay, these are seen in conjunctiva. Okay, next, Kayser-Fleischer rings, okay, which is nothing but deposition of copper in the form of a ring around the eye. Okay, now where do you see this? It is an orange brownish pigmentation. Okay, seen in Wilson's disease. Okay, seen in Wilson's disease. This is seen in cornea. Okay, I am just telling you the parts of the eye. This is seen in cornea. Are you able to see my screen? Vijay? Vijay? Black screen.
స్టాప్ చేయండి ఇది స్టాప్ చేయండి విజయ్ అని గట్టిగా పిలుస్తారేంటి
Yeah. So it started again. Okay, another 10 questions and we'll be done with this session. So we were talking about the eye presentations. Yeah, it started. People who are joining, please can you post the link? Okay. Are you able to see me? Yes. Shrija, please post the link to others. Okay, I'll just wait for them to join. I'm really sorry about the net issues that we are having today. Okay, we have to we are disconnecting, connecting, disconnecting, connecting. There's a lot of issue. I'm really sorry for that. Okay, this is not as smooth as our pro life class, but then we try to do something that is useful for everyone. Okay, not only you as students, our students, which can be helpful to others also who are possible NEET MDS aspirants. Okay, that is the reason we have kept a YouTube live, so that everybody can benefit. Okay, but then again we are having a lot of issues with the connectivity. Okay, so we had seen bitoid spots, we had seen rod spots. Okay, then we had seen Kayser-Fleischer rings. Okay, the next one is a brush field spot. Okay, brush field spot, which is seen in Down syndrome, which is a whitish gray spot that is seen in iris. Okay, so your rod spots are retinal hemorrhages. Okay, then your bitoid spots are seen in the conjunctiva. Okay, then your Kayser-Fleischer rings are seen in the cornea. Okay, and your brush field spots are seen in the iris. Okay, so these different eye spots seen in different parts of the eye, and what are they characteristically diagnostic of? Please remember the disorders. Okay, going to the next question. Okay, Sardinian grin is seen in which of the following? Tetanus, tetany, diphtheria, infectious mononucleosis. Sardinian grin. Is seen in tetanus, tetany, diphtheria, infectious mononucleosis. Very good. It is seen in tetanus. Okay, seen in tetanus. So it is because of Clostridium tetani infection, okay, which causes hyperexcitability of muscles in the face, okay, giving a lock jaw kind of an appearance, which is called as Sardinian grin. Okay, then you can also have extreme arching of the back, that is called as rhizus sardonicus. Okay, so you have rhizus opisthotonus, okay, which is the arching of the back. Okay, this rhizus sardonicus, which is the spasm of the muscles of the face, are called as Sardinian grin. Okay, so this triad of Sardinian grin, which is also called as rhizus sardonicus, and rhizus opisthotonus, which is arching of the back, along with trismus, is called as the tetanic triad. This is called as the tetanic triad. Okay, so tetanus is a infection from the Clostridium tetani, whereas tetany is due to hypocalcemia. Tetany is due to hypocalcemia. Next, which of the following is not a presentation of Fanconi syndrome? Okay, you should know what a Fanconi syndrome is. It is associated with proximal tubule reabsorption, hypervolemia, acidosis, rickets, osteomalacia. Anybody? Which is not a presentation of Fanconi syndrome? Osteomalacia is there. It is hypervolemia. You don't see hypervolemia, you see hypovolemia. Okay, you see acidosis, you see rickets, you see osteomalacia, but you don't see hypervolemia. Okay, so Fanconi syndrome is nothing but proximal tubule reabsorption dysfunction, okay, in which you have phosphaturia, renal glycosuria, okay, there will be proteinuria, okay, and what are the causes? It can be etiologically because of genetic diseases like Winsel's disease, okay, or it can be secondary to dark cisplatin and heavy metals. Okay, so you see a hypovolemia, okay, you see acidosis, you see rickets and osteomalacia, and you also see constipation because of hypokalemia. So the answer for this is A. You don't see hypervolemia, you see hypovolemia. Okay, you see hypovolemia. Next one, excess iodine intake causes hyperproduction of thyroid hormones in which of the following effects? Okay, excess iodine intake causes increase in production of thyroid hormones in Wolff-Chaikoff effect, Jod-Basedow effect, both of the above, none of the above. It is B. It is Jod-Basedow effect. Now, when we look at it, when you give excessive external iodine, if there is decrease in thyroid hormone production, it is called as a Wolff-Chaikoff effect. It is called as a Wolff-Chaikoff effect. When you give excessive iodine, when there is increase in thyroid hormone production, it is called as a Jod-Basedow effect. So I asked lymphocytic virus, HBV. Here he is talking about hepatocellular carcinoma. So which will be the most causative agent of hepatocellular carcinoma? Among the given options? Very good. It is a HBV. So your HBV, HCV are most commonly associated with developing of hepatocellular carcinoma. Okay. Right. So you should know the different types of hepatitis virus. Okay. So enteric transmission is A and E. Others are parenteral transmission. Okay. The longest incubation period is for hepatitis C. Okay. Next, chronic state is not seen in A and E. Okay. So the genetic material is also very important. Okay. So the genetic material is a double-stranded DNA in hepatitis B. Okay. Rest all it is a single-stranded RNA. Okay. And this is also, this double stranded DNA is also partial double stranded DNA. Okay, in hepatitis B. Please remember this. Okay. Next, which of the following markers indicates previous infection in a hepatitis? Anti-HBsAg, anti-HBc, both A and B, HBeAg. He is asking about a previous infection. I will wait for your answers. Very good, Anusha Reddy. Yes, it is both A and B, anti-HBsAg and anti-HBc. Now, when you look at the screen, very, very important, okay. So, the first marker to rise in a hepatitis B infection is your HBsAg. Okay, so it will be present for around 6 months of exposure. After that, your anti-HBsAg will rise. Okay, the second one to rise is your HBeAg. Okay, then around 5 months of after exposure, you have your anti-HBe. Okay, after that, the third marker to rise is anti-HBc. You don't have a HBcAg. Okay, core antigens are not present in the serum of a patient. Okay, so based on this, okay, so he is asking about previous infections. How do you diagnose the previous infection? Presence of anti-HBsAg and anti-HBc are diagnostic of previous infection. So you know acute infection is by HBsAg. This is very, very important. Very commonly they'll ask you acute infection is by HBsAg. Active, if they ask you very active replication, it is by HBe. Okay, active replication is by HBe. Okay, so previous vaccination, if they ask you, it is by anti-HBsAg. Okay, then acute HBV infection, also apart from HBsAg, you see anti-HBc, IgM. Okay, IgM is the first immunoglobulin to increase, followed by IgG. Okay, so please remember, if they ask you acute, it will be IgM. If they ask you chronic, it will be IgG. Okay, so I hope these are clear. Next, all of the following are symptoms of nephritic syndrome except. All of the following are symptoms of nephritic syndrome, acute glomerulonephritis, except oliguria, hematuria, hypertension, massive proteinuria. D. Very good. Massive proteinuria is seen in aortic nephrotic syndrome. Okay. Rest all are seen in nephritic syndrome. So, if you see nephrotic and nephritic, okay. So, this is the nephritic where you see definitely glomerulonephritis, hypertension, cola colored urine, that is your hematuria. Okay. Decreased production of urine, which is your oliguria. Most common causes your Birch's disease, which is a IgA nephropathy. Coming to nephrotic, okay. You see hypoalbuminemia, you see massive proteinuria. Okay, and also you see hyperlipidemia. These are common causes. Okay, so if you see about nephrotic and nephritic, okay, so proteinuria is marked in nephrotic, okay, whereas it's less in nephritic. Okay, hematuria again is present in nephritic, but it is absent in nephrotic. So definitely you don't see a RBC cast in nephrotic, you see it in a nephritic. Okay, so these differences between nephrotic and nephritic are very, very important. Okay, one thing I want to talk about is your Reed-Sternberg cell, which are also called as owl-eye cells, which are seen in Hodgkin's lymphoma. Can you name any other disease in which you see a owl-eye cell? Apart from Hodgkin's lymphoma, where else do you see a owl-eye cell? You see it in CMV. Okay. You also see it in CMV. Very good, Anusha Reddy. You see it in CMV. So, I was talking about hypocalcemia, right? Okay, which is a tetanus, tetany or tetanus. Tetanus is because of Clostridium tetani. Okay, tetany, which is hypocalcemia. Okay. What are these two signs? Just tell me the names of these two signs. Twitching of the facial nerve on application of pressure near the angle of the jaw, seen in hypocalcemia, is called as Schwartz sex sign. This is called as Schwartz sex sign. Okay, and then on application of pressure on the sphygmomanometer cuff, there is flexing of the hand. Okay, this is a carpopedal spasm is seen. This is called as Trocher's sign. It's called as Trocher's sign. Okay, so these two signs are very, very important. Next, parathyroid adenomas are seen in all of the following except men 1, men 2, men 2b, men 4. Why men 4? Very good. It is C. Men 2b, which is also called as men 3. Right? It is also called as men 3. So, if you look at it, okay. So, parathyroid adenomas are seen in men 1, it is seen in men 2a, it is seen in men 4, but you don't see it in men 2b. Okay. So, just have a look at these. Okay. So, men 1 is called as Wermer's syndrome. Men 2a is called as Sippel syndrome. Men 2b is also called as men 3. Okay. And men 4. Okay. So, men 1 is because of chromosome 11. 2a and 2b are because of chromosome 10. And this is because of a cyclin dependent kinase inhibitor gene. 1b gene. Okay. Mutation of that gene. Men 4. Okay. So, you should know what are the common symptoms in men 1, men 2. Okay. These are very, very important. Okay, next one. The presence of gamma-Gandhi bodies is diagnostic of which type of anemia? It's a very easy question. Gamma-Gandhi bodies is diagnostic of which type of anemia? Anusha Reddy, everybody, all of you are correct. It is diagnostic of sickle cell anemia. So, there is a sickling is because of a replacement of glutamine by valine, okay, amino acid. So, because the RBCs assume that sickle shaped, they go and block the arteries, okay, and they lead to excessive bouts of bone pain, okay, retinopathy, bacterial infection, leg ulcers.
7:30 స్టార్ట్ చేశారు.
7:30 స్టార్ట్ చేయలేదా?
7:30 స్టార్ట్ చేశారు. కాకపోతే ఇష్యూస్ రావడం వల్ల ఇంతసేపు పడుతుంది.
15 minutes లేట్ అయింది. ఏ ఇష్యూస్ వల్ల?
7:30 కాదు 7:45
కాదే
7:30
షేర్ కూడా పెట్టాం ఈ గ్రూప్ లో.
స్టార్ట్ అయిందా స్ట్రీమింగ్?
7:45 పెట్టావు కానీ ఆ టైం స్టార్ట్ అయిపోయింది.
Okay, probably the last streaming hopefully for the day. So, the presence of gamma-Gandhi bodies is characteristic of sickle cell anemia. We had seen. Okay. So, sickle cell anemia. Okay. So, the radiographic features are very, very important. Again, you see a hair on end appearance on the skull. Okay. And you see a step ladder pattern. Okay. You see a step ladder pattern on the IUPA. Okay. These are very, very important. The radiographic features of sickle cell anemia. Okay. And on peripheral smear, you see the presence of sickle shaped cells. These are called as drepanocytes. These are called as drepanocytes. Okay. And in the spleen, you see gamma-Gandhi bodies. Okay. So, this is the question that I asked you. Presence of gamma-Gandhi bodies is diagnostic of which anemia? It is sickle cell anemia. Yeah. The next question. Progesterone levels are maximum at what day in menstrual cycle? 11th, 14th, 21st, 18th. Progesterone levels are maximum in which day? Anybody? Yes, Anusha, it's correct. It's 21st day. So if you look at the menstrual cycle, okay, which is the first hormone to rise? You have both the follicular phase and the luteal phase. Follicular phase is between 1 to 14 days and between 14 to 28 days is your luteal phase. Okay, so where do you see progesterone rising? The progesterone is almost flat till the follicular phase, and once the luteal phase starts, it peaks at around 21 days. Okay, this is released by the corpus luteum. Okay, so you should know that peaking of progesterone occurs in luteal phase usually around the 21st day. So the answer for that is 21. Okay. Next, going to the next question. All of the following are features of acromegaly except. All of the features are features of acromegaly except. Height is unaffected. Puberty is unaffected. Hypogonadism, it develops in adulthood. Anybody? Very good, Supraja. It is hypogonadism. Okay. You don't see hypogonadism in acromegaly. So if you see that the differences between acromegaly and gigantism, okay, so look at these three parameters which are unaffected. The height, the onset of puberty and the gonadal development are unaffected in acromegaly, whereas the height is increased in gigantism, onset of puberty is delayed, and hypogonadism is seen in gigantism, but it is not seen in acromegaly. So these three differences between hypogonadism and acromegaly are very, very important. Okay, so height, onset of puberty, gonadal development are unaffected, and height is increased in gigantism, onset of puberty is delayed, and there is hypogonadism in gigantism. Okay, last question. Fetal hemoglobin has which of the following chains? Epsilon, beta, gamma, delta. Epsilon, beta, gamma, delta. I am talking about fetal hemoglobin. Yes, Supraja, you are correct. Correct, Mansi, it is gamma. Okay. So if you talk about a normal adult hemoglobin, it has alpha 2, beta 2 chains. Okay. Now these beta 2 chains can be replaced by delta 2 chains. Okay. In certain population, then the hemoglobin becomes HbA2. Okay. HbA2. Okay. In fetus, the hemoglobin beta chains are replaced by gamma chains. Okay. Alpha 2 gamma 2 is fetal hemoglobin. So this fetal hemoglobin can convert into either HbA or HbA2. Okay. So these chains of different types of hemoglobin are important. Okay. And in HbS, that is your sickle cell anemia, it is alpha 2 beta 2 only, but there is glutamate is replaced by valine in the 6th position in sickle cell anemia. Okay, in sickle cell anemia. Right? Yeah, so as you can see, I wanted to discuss a lot of slides, okay, but there is a lot of issue with the internet, so we are not going about discussing everything in detail. So we just wanted to have a rapid revision on your general medicine, physiology and pharmacology before we go for the grand exam, which is on the 13th of this month, that is day after tomorrow. So it is going to be very, very useful for you. So I will definitely ask you all to come on the 13th and give the exam. Okay, please make it a matter to give your grand exam on 13th. You can assess yourself how much you know, how much you don't know, where you have to improve. Okay, this is a very, very important module, which is very, very important for you all to understand. Okay, so please, we have conducted so many pro life classes, so many offline classes, and we try to take YouTube lives and enormous amount of discussions on WhatsApp. So please do attempt your exam on the 13th of this month. Okay, so all the very best. I'm really sorry for the multiple browsings that had to be done today, okay, because of the internet issue we had today. Okay, so see you all. Have a very nice weekend. Okay, it's a long weekend, make maximum use of it, and please study well, and all the very best for your exam. Thank you so much. See you all once again. Bye bye.